Welcome back. My name is Dr. Conwell. This is Module 2 of my 3-part series on the deep tendon reflexes. In Module 1, we built the foundations. We defined what a deep tendon reflex is and its physiological purpose. We placed it within the neurological examination, and we worked through the anatomy of the reflex arcs, the myotatic stretch reflex, reciprocal inhibition, and the inverse myotatic reflex. Module 2 now moves from anatomy to assessment. We will examine the physiology that drives the reflex, conduction, synaptic speed, and descending control. We will identify the spinal cord levels that correspond to the clinically tested reflexes. We will introduce the Wexler grading scale, the standardized scoring system that runs from 0 for an absent reflex to 5+ for clonus, and we will learn to interpret these findings to differentiate a normal reflex from the patterns seen in lower and upper motor neuron lesions. Module 3 will then take these principles to the bedside, to pathological reflex changes, lesion localization, and examination technique. By the end of this module, you will understand the physiology behind the reflex, the spinal levels you are testing, and how to grade and interpret what you find. Here's the path Module 2 will take, divided into 3 chapters. Chapter 5, Neurophysiology and Modulation, examines how the reflex signal travels, the conduction of the impulse, the speed of the synapse, and the descending control from higher centers that can either facilitate or restrain the response. Chapter 6, Clinical Application, brings this to the examination itself, the spinal cord levels of each reflex you test, the Wexler scale used to grade them, and the first principles of localizing a lesion from the pattern you observe. Chapter 7, Neuropathology, turns to the abnormal, how reflexes change in disease, and how those changes help you identify the site of the lesion. We will take these in sequence, building from the physiology to the examination to the interpretation. Chapter 5 shifts from anatomy to physiology. Specifically, we're going to examine conduction speed, synaptic transmission, and the crucial topic of descending modulation. Understanding why the reflex is fast and understanding who supervises it from above will give you the physiological foundation you need to explain why upper motor neuron lesions produce hyperreflexia rather than hyporeflexia. That explanation is not intuitive at first, but by the end of this chapter, it will be completely logical to you. Let's work through it. Before we examine the DTR in detail, let me give you the general framework of all reflex arcs, because it applies to every reflex in the nervous system. A reflex arc has 5 components. 1. The receptor, a sensory ending that detects the stimulus. In the stretch reflex, that's the muscle spindle detecting length change. 2. The afferent, or sensory neuron, carries the signal from the receptor into the spinal cord via the dorsal root. For the stretch reflex, this is the 1A fiber. 3. The integration center, where the signal is processed in the CNS. In the monosynaptic stretch reflex, this is a single synapse in the ventral horn. In the reciprocal inhibition and inverse myotatic reflexes, there are additional interneurons, making those polysynaptic. 4. The efferent, or motor neuron, carries the command back out to the muscle. The alpha motor neuron exits through the ventral root. 5. The effector, the muscle that responds by contracting. This produces the visible reflex response. Receptor, afferent, integration, efferent, effector. Know this sequence. When a reflex is absent or abnormal, your job is to identify which component of this arc has been disrupted. That is lesion localization. The alpha motor neuron is so important it deserves its own slide, and I want to spend a moment on the concept of the final common pathway. Every motor command that the brain generates, voluntary movement, postural adjustments, reflexes, whatever the origin, must ultimately flow through the alpha motor neuron to reach muscle. It is the last neuron in every motor chain. There is no alternative route. This is why the alpha motor neuron is called the final common pathway, and this is also why it is synonymous with the term lower motor neuron. The anatomy, cell body in the ventral anterior horn of the spinal cord gray matter. Axon exits through the ventral root, travels in the peripheral nerve, and terminates at the neuromuscular junction with acetylcholine release. The motor unit, one alpha motor neuron plus all the muscle fibers it innervates. The motor unit is the smallest functional element of movement. Different muscles have very different motor unit sizes. The extraocular muscles have units of just a few fibers for precise control, while large limb muscles have units of hundreds of fibers for force generation. The clinical implication is direct. If you damage the alpha motor neuron or its axon anywhere along its course, whether at the cell body, in the anterior horn, in the ventral root, or in the peripheral nerve, the reflex arc is broken. The signal cannot complete. The result is hyporeflexia or areflexia, the hallmark of lower motor neuron disease. Study this anatomical diagram carefully. Notice the cell body position in the ventral horn of the spinal cord, the gray matter. The axon travels in the white matter briefly before exiting through the ventral root, then joins the peripheral nerve to travel to the muscle. Pay attention to the size of this neuron. Alpha motor neurons are among the largest neurons in the nervous system. Their axons are heavily myelinated, type A alpha fibers, for fast conduction of motor commands. Trace the path from cell body to neuromuscular junction. Every millimeter of that axon is a potential site of pathology. Anterior horn cell disease like ALS damages the cell body. Root compression from a herniated disc damages the proximal axon. Peripheral neuropathy damages the distal axon. All of these interrupt the same final common pathway, producing the same clinical signature: weakness, hyperreflexia or areflexia, flaccidity, and eventually atrophy. The motor unit is also depicted here. One alpha motor neuron innervating multiple muscle fibers. Each fiber receives its sole motor innervation from this one neuron. If the neuron dies, those fibers lose all input. That is why LMN damage causes atrophy and fasciculations in a pattern corresponding to the denervated territory. Alongside the alpha motor neuron, a smaller motor neuron also exits the ventral horn, the gamma motor neuron, also called the fusi-motor neuron. The gamma motor neuron does not power movement. It controls the muscle spindle itself. Here's the problem it solves. When a muscle contracts, its extrafusal fibers shorten. If the intrafusal fibers of the muscle spindle didn't also shorten, the spindle would go slack. A slack spindle can't detect stretch. The reflex would be temporarily blind every time the muscle contracted. That would be a serious physiological liability. The gamma motor neuron prevents this by contracting the ends of the intrafusal fibers simultaneously with the extrafusal contraction. This keeps the spindle taut, under tension, and responsive throughout the full range of motion. This is the concept of alpha-gamma coactivation. When the motor cortex commands a movement, it doesn't just send a signal to the alpha motor neuron. It simultaneously activates the gamma motor neuron, keeping the spindle calibrated for the movement that's about to happen. The clinical implication: if you damage only the gamma motor neurons, you don't lose strength, extrafusal contraction is intact, but you impair the spindle's ability to monitor and adjust. Muscle tone and proprioception are affected. For the DTR specifically, if the gamma system is suppressed, as happens in certain pathological states, spindle sensitivity drops and reflexes can appear reduced, even though the alpha motor neuron pathway is intact. This can be a source of diagnostic nuance. Here you can see the gamma motor neuron in anatomical context relative to the alpha motor neuron and the muscle spindle. Notice that both neurons originate in the ventral horn and exit through the ventral root. They travel together in the peripheral nerve, but they diverge at the muscle. The alpha motor neuron terminates on extrafusal fibers. The gamma motor neuron terminates on the polar ends of the intrafusal fibers. The intrafusal fiber has three regions: two contractile polar ends, innervated by the gamma motor neuron, and a central equatorial region that contains the sensory ending of the 1A afferent. When the gamma motor neuron pulls on the polar ends, it stretches the equatorial region, increasing spindle sensitivity. This architecture is why the spindle is not merely a passive receptor. It is an actively tuned sensor whose sensitivity can be adjusted in real time based on the task being performed. Precision tasks requiring fine motor control may require higher spindle sensitivity. Coarse power movements may require less. Let's consolidate with this comparison table because these two neuron types are often confused on examinations. Alpha motor neuron, also called the lower motor neuron, cell body in the ventral anterior horn. Target: extrafusal muscle fibers, the ones that produce force. Function: powers movement. It is the final common pathway for all motor commands. Large, heavily myelinated axon for fast conduction. If damaged, weakness, atrophy, fasciculations, and lost reflexes, the classic LMN signs. Gamma motor neuron, also called the fusomotor neuron, Cell body also in the ventral horn, same location. Target, intrafusal fibers of the muscle spindle. Function, sets spindle sensitivity, calibrates the sensor, keeps the reflex arc responsive during contraction. Smaller, less myelinated axon. If damaged, altered muscle tone and impaired proprioception, but not the frank weakness and atrophy seen with alpha damage. The key point, alpha powers the muscle. Gamma calibrates the sensor. Together, via co-activation, they keep the stretch reflex functional across the full range of motion. When you see a reflex abnormality on your boards or at the bedside, you're almost always dealing with alpha motor neuron pathology. That's where LMN signs originate. But knowing about the gamma system helps you understand the more nuanced presentations. This is a concept I love because it illustrates how the nervous system optimizes a circuit for a specific function. Why is the DTR so fast? Two factors working together. First, the wire. Ia afferent fibers are among the largest, most heavily myelinated nerve fibers in the body. Their myelin sheaths are thick and the nodes of Ranvier are widely spaced. Conduction occurs by saltatory transmission. The action potential jumps from node to node, skipping the myelinated internodal segments. The result, conduction velocities of 80 to 120 meters per second. That is fast. To put it in perspective, that signal can travel the full length of your leg in under 10 milliseconds. Second, the synaptic shortcut. The Ia afferent makes a single direct synapse with the alpha motor neuron. No interneurons, no intermediate steps. Each synapse introduces a delay, typically 1 to 2 milliseconds. The stretch reflex has exactly one synapse. The withdrawal reflex, by comparison, routes through multiple interneurons and is correspondingly slower. Combined effect, a fast wire plus the shortest possible synaptic path produces a signal that goes to the cord and returns to the muscle in a fraction of a second, far faster than any voluntary response can be initiated. This speed serves the protective function of the reflex. If you need to prevent a muscle from being overstretched, you cannot wait for a voluntary response. You need an automatic, high-speed circuit. That is exactly what the DTR is. Now we come to the concept that explains some of the most important clinical findings in neurology: descending modulation of spinal reflexes. Here is the key insight. The spinal cord can run the reflex arc on its own. The circuit doesn't need the brain. You could sever the spinal cord above the reflex level and the reflex would still fire, eventually after spinal shock resolves. The arc is autonomous. But in the intact nervous system, the brain is always supervising. Descending pathways from the cortex and brainstem continuously send signals down to the spinal cord that modulate how strong the reflex response is allowed to be. Two descending systems matter most for us. First, the corticospinal tract. Motor cortex input provides tonic inhibition to spinal reflex circuits. The net effect is primarily inhibitory. It keeps reflexes damped down to a level appropriate for smooth, controlled, voluntary movement. Think of it as a brake pedal. Second, the reticulospinal tract. This system is more modulatory. It can be excitatory or inhibitory depending on context. Postural demands, arousal level, and the intended movement all influence how this system adjusts reflex sensitivity. Think of it as a dimmer switch. Why does this matter? Because now you can answer the question that every student asks. Why does an upper motor neuron lesion cause hyperreflexia? If the lesion damages the brain or the corticospinal tract, the brake is gone. The spinal reflex arc is intact but no longer inhibited. The reflex runs unchecked. Hyperreflexia is not the reflex being overactivated. It is the reflex being disinhibited. The brake has been removed. That is the mechanism. This slide is the pivot point of the entire lecture. Everything before this moment has been building to this distinction. When modulation is lost, two patterns emerge, and they are opposite to each other. Upper motor neuron lesion. The brake fails. The corticospinal tract is damaged. Descending inhibition to the spinal reflex arc is lost. The arc itself is completely intact, but without the brake, the reflex runs unchecked. The UMN signs, hyperreflexia, exaggerated reflexes below the lesion, increased tone, spasticity, pathological reflexes, Babinski sign, Hoffman sign. These findings all occur below the level of the lesion, because those are the arcs that have lost their inhibitory supervision from above. Common causes: stroke, spinal cord injury, multiple sclerosis, wherever the corticospinal tract is damaged. Lower motor neuron lesion. The arc breaks. Here the damage is to the alpha motor neuron or its axon. The reflex circuit itself is disrupted. The arc cannot complete. No response is possible. The LMN signs: hyporeflexia or areflexia, decreased tone, flaccidity, atrophy, fasciculations. These findings occur at the level of the lesion, focal, segmental, corresponding to the specific root or nerve damaged. Common causes: radiculopathy, peripheral neuropathy, anterior horn cell disease. The single most important mnemonic in this lecture: UMN releases the reflex. Everything goes up. LMN breaks the reflex. Everything goes down. This distinction is the most tested concept in clinical neurology. You must have it automatic. Chapter 6. This is where we translate everything we've learned into clinical practice. We're now going to cover reflex levels and their spinal cord correspondences, the Wexler grading scale for standardized documentation, and the localization framework that ties everything together. This chapter is the most directly applicable to your clinical rotations, your board examinations, and your day-to-day practice. Pay close attention. Let's map the upper extremity reflexes to their spinal levels. 3 reflexes, 3 nerve roots. You need to know all of them. Biceps reflex, root level, C5 and C6. Nerve, musculocutaneous. Test site, the biceps tendon in the antecubital fossa. The examiner's thumb or finger is placed on the biceps tendon, and the hammer strikes the examiner's thumb. A normal response is a visible or palpable biceps contraction with mild forearm flexion. Brachioradialis reflex, root level, C5 and C6, same as the biceps, but mediated through the radial nerve. Test site, the styloid process of the radius. The hammer strikes the brachioradialis tendon directly. Normal response, forearm flexion with some radial deviation. Triceps reflex, root level, C7 and C8. Nerve radial. Test site, the triceps tendon just proximal to the olecranon. The arm is supported in slight flexion, and the hammer strikes the tendon directly. Normal response, visible triceps contraction and forearm extension. Note the clinical utility. If a patient has weakness and sensory loss following a cervical disc herniation and the biceps reflex is absent but the triceps is intact, that's a C5 or C6 lesion, not C7. The reflex gives you the level without imaging. Print these. Seriously. Take a photo of this slide right now if you need to. These charts are the clinical tools you will actually use. In the first weeks of your neurology rotation, you will be expected to recall these root levels without hesitation. There is no substitute for drilling them until they are automatic. Upper extremity summary, 3 reflexes. Simple pattern, C5 to C6 covers both the biceps and the brachioradialis. 2 reflexes, same root level. C7 to C8 covers the triceps alone. A practical study approach. Test these on your classmates, on your study partners, on your family if you can convince them. Physical repetition of the exam technique alongside the verbal drill of the root levels is far more effective than passive review. The goal is zero latency recall. When someone says biceps reflex, you say C5 to C6 musculocutaneous without thinking. That is the standard. Now the lower extremity. 2 reflexes are essential. The patellar and the Achilles. I'll add the medial hamstring for completeness, but the patellar and Achilles are the ones you will test on every patient. Patellar reflex, also called the knee jerk. Root level, L3 and L4. Nerve, femoral. Test site, the patellar tendon just inferior to the patella. The patient's leg should be relaxed and slightly flexed, ideally with the lower leg hanging freely or supported over the examiner's arm. The hammer strikes the patellar tendon directly. Normal response, visible quadriceps contraction and knee extension. Achilles reflex, also called the ankle jerk. Root level, S1 and S2. Nerve, tibial. Test site, the Achilles tendon above the heel. The foot should be slightly dorsiflexed. The hammer strikes the Achilles tendon. Normal response, plantar flexion of the foot. Clinical application. A patient presents with low back pain radiating into the leg. The patellar reflex is absent on the left, but the Achilles is present bilaterally. That single finding points you to an L3 to L4 lesion on the left, likely an L3 to L4 disc herniation compressing the L4 root. You have a localization before you've ordered a single imaging study. Again, print this, photograph it, or write it out by hand. These charts are your clinical reference. Lower extremity summary, L3 to L4, patellar reflex femoral nerve, S1 to S2, Achilles reflex tibial nerve, simple and clean. The lumbar reflex covers the quadriceps. The sacral reflex covers the gastrocnemius soleus complex. Here's a high-yield pearl. In peripheral neuropathy, the Achilles reflex is almost always the first to go. The S1 reflex arc involves the longest peripheral nerves in the body. Anything that damages nerve fibers in a length-dependent pattern will affect these long fibers first. An absent Achilles reflex in an elderly diabetic patient is one of the most common neurological findings you will encounter, and it tells you something immediately. This patient has distal first nerve fiber loss. Now you understand why, not just what. We need a standardized language for describing reflex findings, and that language is the Wexler grading scale. The scale runs from 0 to 5+, and I want you to understand what each grade means mechanistically, not just numerically. 0, no response. The reflex arc is silent. The tendon tap produces no muscle contraction. Even with reinforcement, no response can be elicited. 1+, a trace response, requires reinforcement, typically the Gendrasic maneuver, to be detectable. This is borderline and must be interpreted cautiously. 2+, normal. A brisk, symmetric response appropriate to the stimulus. This is your baseline. 3+, brisk, slightly hyperactive. More response than expected for the stimulus. May be normal in an anxious patient, but warrants comparison with the other side and correlation with tone and strength. 4+, hyperactive with clonus. The muscle contracts more than once in response to a single tap. There is a rhythmic oscillation. This is pathological. 5+, sustained clonus. The rhythmic oscillation continues as long as you maintain pressure on the tendon. This is strongly indicative of an upper motor neuron lesion with loss of descending inhibition. 2+ is normal. Everything below is suppressed. Everything above is released. Now the key clinical points for applying the Wexler scale at the bedside. First and most important, asymmetry trumps absolute grade. A patient who is bilaterally 3+, symmetric, is probably fine. A patient who is 3+ on the right and 2+ on the left has a significant finding, even though neither grade is individually alarming. Unilateral exaggeration of a reflex, even within the borderline normal range, can point to a focal lesion. Always compare both sides. Second, use the Gendrasic maneuver before recording 0 or 1+. Have the patient interlock their fingers and pull laterally while you test the lower extremity reflexes. This technique increases baseline motor neuron excitability through descending pathways, unmasking a reflex that may be suppressed by voluntary inhibition or anxiety. If the reflex appears after reinforcement, it's a 1+, not a 0. That distinction matters. Third, clonus, grade 4+ versus 5+. Both indicate pathological hyperreflexia and UMN involvement, but sustained clonus, grade 5+, carries stronger localizing value. Unsustained clonus, grade 4+, can occasionally be seen in anxious but neurologically intact individuals. The clinical context matters. Fourth, document left and right separately every time. Patellar 2+ bilaterally is an adequate note. Patellar R 3+L1+ is a clinical finding requiring explanation. When do you test deep tendon reflexes? The short answer is in almost any patient with a neurological complaint. The clinical indications fall into several categories. First, any complaint involving weakness, numbness, or tingling. These symptoms may reflect pathology anywhere from the motor cortex to the peripheral nerve, and DTR testing helps you localize. Second, radiculopathy. A patient with neck pain radiating down the arm or back pain radiating down the leg deserves a reflex examination to identify the affected root level. Third, myelopathy, spinal cord compression. Hyperreflexia below the level of compression, combined with a normal or diminished reflex at the level itself, is a classic presentation. Fourth, peripheral neuropathy, symmetric distal reduction or absence of reflexes. Achilles first is a hallmark. Fifth, any presentation where UMN versus LMN distinction is needed. DTRs are one of the primary tools for making that distinction. And sixth, periodic neurological examination in patients with known conditions affecting the nervous system, stroke, MS, diabetes, ALS. Serial reflex findings, document progression or recovery. Bottom line, if a patient has a neurological symptom, include reflexes in your examination. They take 60 seconds and provide information you cannot get any other way. This comparison table is the most exam-critical content in the entire lecture. I want you to read every row, understand it mechanistically, and be able to reproduce it from memory. We'll go feature by feature. Deep tendon reflexes. UMN. Hyperreflexia below the lesion. The arc is intact but disinhibited. LMN. Hyporeflexia or areflexia at the level. The arc is broken. Muscle tone. UMN. Increased tone, spasticity, often with the clasp knife quality. LMN. Decreased tone, flaccidity. The muscle is denervated and loses its normal resting tone. Muscle bulk. UMN. Normal or mild disuse atrophy only. The muscle is still innervated, just out of cortical control. LMN. Marked neurogenic atrophy. Denervated muscle fibers lose trophic support and waste. Fasciculations. UMN. Absent. The lower motor neuron is intact, so there are no spontaneous discharges. LMN. Present. Denervated or dying. Motor neurons fire spontaneously, producing the visible twitching of fasciculations. Plantar response. UMN. Babinski sign. Upgoing toe. The release of descending inhibition allows a primitive reflex to emerge. LMN. Flexor plantar response. Normal or absent. Weakness pattern. UMN. Pyramidal distribution. Distal upper extremity and the entire lower extremity, following the anatomy of the corticospinal tract. LMN. Segmental or focal. Specific muscles corresponding to the damaged root or nerve. Typical causes. UMN. Stroke, MS, spinal cord compression, LMN, radiculopathy, peripheral neuropathy, Guillain-Barré, motor neuron disease. The mnemonic, one more time. UMN. Everything up. LMN. Everything down. This is your synthesis slide. Everything you need for rapid reflex interpretation in one place. The 5 essential reflexes with their root levels, nerves, and test sites. Biceps, C5 to C6, musculocutaneous, biceps tendon, brachioradialis, C5 to C6, radial, styloid process. Triceps, C7 to C8, radial, triceps tendon. Patellar, L3 to L4, femoral, patellar tendon. Achilles, S1 to S2, tibial, Achilles tendon. Wexler scale at a glance. 0 absent, 1 plus trace, 2 plus normal, 3 plus brisk, 4 plus clonus, 5 plus sustained clonus, and 4 clinical pearls to anchor your exam technique. First, asymmetry trumps absolute grade. A unilateral 3 plus versus a 2 plus on the other side is a finding. Bilateral 3 plus is usually not. Second, Gendrasik maneuver to differentiate a true 0 from a suppressed 1 plus. Always reinforce before calling a reflex absent. Third, always compare bilaterally. Test the same reflex on both sides before moving to the next. Never test all right, then all left. Fourth, grade 4 plus versus 5 plus. Both are abnormal UMN findings, but sustained clonus carries stronger localizing value. Use this slide as your bedside reference until these reflexes are automatic. At that point, you won't need it anymore. Chapter 7 takes us into the pathology, abnormal reflex findings, and how to use them to identify the site of a lesion. This is where the anatomy, physiology, and clinical examination all converge. Everything you've learned so far was preparation for this section. The core clinical task is this. You find an abnormal reflex, and you need to answer 2 questions. 1. Is the arc broken, or is the arc disinhibited? 2. Where precisely is the problem located? The answers to both questions are contained in the reflex pattern itself. Here is the 4-step algorithm I want you to use every time you encounter an abnormal reflex finding. Walk through these steps in order. Step 1. Is the reflex increased or decreased? This single question separates the 2 fundamental categories of pathology. Hyperreflexia points above the arc to an upper motor neuron lesion. Hyporeflexia points to the arc itself, a lower motor neuron problem. Don't go further until you've answered this question clearly. Step 2. If hyperreflexia, the reflexes rise below the lesion. Here's why. Descending inhibition from the corticospinal tract is lost. Every spinal reflex arc below the damaged level is now disinhibited. The highest level of hyperreflexia marks the lower boundary of the lesion. Everything above that level has intact corticospinal input, and those reflexes are normal. Step 3. If hyporeflexia, the reflex drops at the level of the lesion. The arc itself is broken at a specific segment. A lost patellar reflex points to L4. A lost Achilles reflex points to S1. The reflex names the root. Step 4. Compare bilaterally to lateralize. A side-to-side difference indicates a focal, unilateral lesion. Symmetric changes suggest a diffuse process, peripheral neuropathy, a central cord lesion, metabolic disease. The worked example on this slide is worth your attention. Brisk knee and ankle reflexes with a normal biceps reflex. That pattern localizes the lesion to the spinal cord below C5 to C6 but above L2. The reflexes themselves draw the anatomical boundary. 4 steps. Every abnormal reflex finding fits into this framework. Let's solidify the interpretation framework with this 3-part summary. Hyporeflexia, diminished or absent reflexes. What it means, sign of lower motor neuron dysfunction. The reflex arc itself is damaged or interrupted at some point along its course. The signal cannot complete, seen in peripheral neuropathies. The afferent or efferent limb of the arc is damaged in the peripheral nerve. Nerve root compression. The arc is interrupted at its entry or exit from the cord. Anterior horn cell disease. The motor neuron cell body is destroyed. Clinical clue. The reflex drops at the level of the lesion. The deficit is focal and segmental. Hyperreflexia, exaggerated reflexes. What it means, classic sign of upper motor neuron pathology. The arc is intact, but the descending brake has been removed. The reflex runs unchecked. Seen in stroke, corticospinal tract damaged in the brain, spinal cord lesions above the level of the arc, demyelinating disease such as MS, plaques interrupting descending tracts. Clinical clue, reflexes rise below the level of the lesion. The highest normal reflex marks the border. Asymmetry, unequal side to side. What it means, one side is affected, the other is spared. Points to a focal lesion, one root, one nerve, one tract, one side of the cord. The takeaway in 3 symbols, down arrow equals arc broken, LMN. Up arrow equals arc released, UMN. Left does not equal right equals focal lesion. The pattern tells you where. This table integrates reflexes with the full clinical picture, tone, strength, sensation, and other findings. This is how you actually practice clinical neurology. You don't interpret reflexes in isolation. You correlate them with everything else you find on examination. Let's read through each pattern. Hyporeflexia, the LMN pattern. Diminished or absent reflexes, Wexler 01+. Decreased tone, flaccidity. Weakness following a specific myotome. May have associated muscle atrophy if the denervation is not acute. Fasciculations, dermatomal sensory loss. Babinski absent. The lower motor neuron arc for the flexor plantar response is intact, but the patient has normal plantar flexor response. Localization at the level of the lesion. Hyperreflexia, the UMN pattern. Brisk or exaggerated reflexes, Wexler 3 to 4+. Clonus may be present. Increased tone, spasticity, weakness in pyramidal distribution, no early atrophy. The muscle is still innervated. Positive Babinski, positive Hoffman. Localization below the level of the lesion. Asymmetry, the focal pattern. Unequal side-to-side reflexes, unilateral change in tone and weakness, may be spastic or flaccid depending on the level. Unilateral sensory findings. Unilateral Babinski or sensory level. Consider Brown-Séquard syndrome. Localization, focal. Compare left and right to pinpoint. Key insight, reflexes alone don't diagnose. Pair them with tone, strength, sensation, and bilateral comparison to distinguish UMN from LMN and localize the lesion. I want to briefly introduce pathological reflexes as bonus material. These will come up in your clinical rotations and on your boards, and they extend the concept of descending modulation we've been discussing. Pathological reflexes are primitive motor responses that are present in infants, gradually suppressed as the corticospinal tract matures during the first 2 years of life, and then reemerge when UMN pathology removes that suppression. The most important one you must know is the Babinski sign. To elicit it, use a blunt instrument to stroke firmly along the lateral plantar surface of the foot from the heel toward the base of the toes, then across to the great toe. A pathological response, the Babinski sign, consists of dorsiflexion of the great toe, often with fanning of the other toes. This upgoing toe is a UMN sign. A normal adult response is plantar flexion of all toes. The Hoffman sign is the upper extremity equivalent. Flick the distal phalanx of the middle finger downward. A positive response is flexion of the thumb and index finger. An abnormal response that indicates UMN pathology in the cervical cord or above. Both of these signs, Babinski and Hoffman, appear when descending corticospinal inhibition is lost. They are not present in LMN disease. Learning to elicit and interpret them properly is a core clinical skill.
Before we close, let me leave you with 3 things. First, if today's lecture reinforced the value of a rigorous, systematic approach to the neurological reflex examination, I want you to know about a resource that takes that approach much further. The Clinical Picture, Essentials of the Neuromusculoskeletal Exam, is a comprehensive clinical reference covering the complete neuromusculoskeletal workup, the history, the physical examination, neurological and orthopedic evaluation, clinical case studies, and full documentation, including narrative reports and SOAP charting. It is the only text that takes you from examination findings all the way through to a finished clinical record in a single, concise volume. Whether you are preparing for board examinations, entering your clinical rotations, or you simply want a reference that translates neuroscience into practical documentation, this textbook belongs on your desk. It is available now on Amazon. The link is on your screen and in the description below. Second, before you move on, put today's material to the test. This module includes a complimentary board preparation flashcard set, 50 board-style examination questions, each with a detailed explanation and rationale, available now at theclinicalpicture.com/lecture series. And here is my challenge to you. Don't just read the answers. Reason through each question first, and then reveal the explanation. That process of active recall is one of the most powerful ways to strengthen retention, sharpen your clinical reasoning, and build the confidence you'll need on your boards and with the patients you will care for throughout your career. And third, Module 3, the final lecture in this series, is where everything comes together at the bedside. We will apply reflex changes to upper and lower motor neuron pathology, localize the lesion from the pattern of findings, and demonstrate proper examination technique for the upper and lower extremities. This is where the science becomes the skill. I look forward to seeing you there. If this lecture deepened your understanding of this important clinical topic, please subscribe, like, or leave a comment below. It genuinely helps me produce more content like this. Thank you for watching.